Janet, thank you again for sharing your story. I had the chance to hear Janet speak at a meeting put on out in San Diego, the Singularity Exponential Medicine meeting. And I immediately emailed her and said, we need to hear that voice here at this meeting. We talk a lot about patient-centered outcomes. I think that Janet is reminding us about the ultimate patient-centered outcome, listening and understanding. I also think it's interesting in light of this panel because this panel is really looking at a full circle, which is something that FasterCures hasn't had enough capacity to do until now. And also the Milken Institute has more capacity to look at some of these issues as well. So we are joined in this panel by an amazing group, and I've asked each of them to start us off with a little story, a little bio about who they are and why this topic matters to them. What we'll be doing in this panel is going through kind of a journey of who these folks are that are sitting up here with me, who got up early, as did all of you. Not as early as Mike, I'm sure, who started early this morning with a session. We'll understand a little bit about their journey. We'll look at what do we know about this topic, not just about prevention, but about precision health, which is something that Lloyd is going to talk a lot about. Then we're going to look at what's happening now out in the field. What are we actually deploying? And then at the end, what needs to happen? What is the system that we really need to create? The Milken Institute has done a lot of work over the years on this issue. Ross Duvall has led a number of studies looking at the impact of chronic disease. And so you'll hear probably a little bit about some of that work. And then we have a new center that is looking at public health. So at FasterCures, we're delighted to be able to kind of bring the circle closed. But let's kick off, Kelly, with you, giving us a little bit about your story and what does this topic mean to you?
Absolutely. So good morning. Thank you so much to FasterCures for having this critically important discussion this morning, and what an honor to be here. So my piece of this, I work on diabetes and obesity. I've had diabetes for 30 years. Diabetes and obesity are bankrupting our country. We need to focus far, far more on prevention, and this is become critically important over time. So I was diagnosed as a teenager. That was, many years ago. It wasn't 100 years ago, that was about 30 years ago. And back then, there were about 1 in every 180 people globally had diabetes. So today, that number is 1 in 11. People are not doing that much better than they were even a decade or 2 decades ago, even though there's phenomenally better science. The science is not the problem at all. It is all of the pieces around it. And we would love to see more focus on behavior change. We'd love to see more focus on public attitudes and stigma. There are so many opportunities across systems to improve care, and we obviously are going to be talking a lot more today about prevention. One cool thing that I can say, in just watching the elections, one bright spot in the elections over the last week has been watching the soda taxes and the level of discussion of prevention in that piece alone. San Francisco, Oakland, Albany, even Chicago, Boulder, they followed the pioneers of Berkeley and Philadelphia. And I think there is a lot else that could happen there. And I'm happy even for just the dialogue that has sparked.
Fantastic. And then you said that you were perhaps live tweeting, is that right?
Yes,
all right.
If that's all right.
So if you see her on her phone, she's not multitasking in a bad way. She's doing it for her community. Your community is how large?
Yeah, so I run the diaTribe Foundation. This is a community based in the San Francisco Bay Area. So we have about 100,000 people who subscribe to our newsletter. This is grown from about 20,000 about 3 years ago when the Helmsley Charitable Trust decided to start funding us, and we became a nonprofit. So many thanks to the Helmsley Charitable Trust for that. We also we have about 2 million people who visit diaTribe.org every year.
Fantastic. Lloyd, can you tell us a little bit about your journey and how you got interested in health and doing the work that you're doing today, leading the Stanford School of Medicine?
Yes, and Margaret, thank you very much for inviting me here today, and Mike, thank you as well for all you've done to make FasterCures and so many other things a reality in our society today. So by background, I'm a clinician scientist. I focused in the early stages of my career on a study of inner ear balance disorders and defined a new clinical syndrome, developed a surgical treatment for that, and really sought to bring the best basic science to understanding and ultimately treating disorders of the vestibular system, the inner ear balance system. I had an opportunity to be a leader, and then 4 years ago, I had an opportunity to move to Stanford to be Dean of Medicine. And around that time also, we began to see this convergence of so many different technologies and branches of science converging on biomedical problems. And truly, I think this is the decade, indeed the century, of the biomedical revolution. And the same enablers that we have seen that have been so effective to drive precision medicine, those same enablers of genomics, big data science, regenerative medicine can be applied and are being applied in a predictive, preventive, and proactive way. So that we have within our grasp the opportunity to prevent diseases before they occur, or when we can't prevent them, to develop new diagnostic techniques that diagnose them before they need to be treated with the armamentarium that we're developing in precision medicine. So the way we know we will have succeeded a decade from now in precision health is that the need for precision medicine to treat the most severe acute and chronic diseases, that need will be reduced. You know, for as long as people have been treating and caring for the sick, we've been playing a frantic game of catch-up. A frantic game of catch-up, all too often diagnosing diseases far too late in their course, where interventions are not nearly as effective as they could have been if the diagnosis had been made earlier or if the disease had been prevented altogether.
Fantastic, and we're going to hear more about what the future looks like from your perspective, talking to medical school students and training them for this future. So I would like to go to Esther next. If you can tell us a little bit about your background. It didn't start in this particular issue, did it?
So thanks, I'm delighted to be here, like everyone. I began as a journalist, a Wall Street analyst. I learned economics, and so the one skill I really had was asking questions. I ended up being in the tech world for 25 years, and towards the end, I began to think, a lot of this stuff is kind of frivolous and not tremendously useful. So I spent a little more time looking at healthcare. Among other things, I interviewed a guy called Charlie Silver, who had created a website called Real Age, which he then sold to Hearst and is now part of ShareCare. It asks you, do you argue with your spouse? How much exercise do you get? What do you eat? And I think in some way it's done a lot more for health than many kind of precision medicine things. But its business purpose is to sell vitamin supplements. However, the most interesting thing about Charlie was his first company. Instead of selling it to Hearst, he sold it to Jiffy Lube. It was car maintenance. And I thought, we really do a much better job with oil changes and car maintenance than we actually do with all this other stuff. And what could the business model be? So lots of other things happened, but in the end, I thought somebody should do something like a healthcare X Prize, which had in fact existed, but never happened. And thought somebody should do a health X Prize instead of a care X Prize. I was about to say on stage somewhere that somebody should do that and realized, not a great talk. So I announced it. That was May of 2013. And now I'm the executive founder of Way to Wellville, which I'll talk about a lot more, which operates in 5 small communities to cultivate health rather than to extend health care. We want to make health care not cheaper, but less needed, just as what Lloyd was saying.
Fantastic. So Joe, you run PCORI, but you have a long background in the sort of prevention public health space. You were at Kaiser before coming to PCORI. I feel like I read something in your bio about, you had some epiphanies early on about wanting to do this work, and certainly in the pre-calls you talked about things that you saw as you were doing your work that really had an impact on you and made you want to focus in on sort of applying all of this for prevention. Can you tell us a little bit about your backstory?
Sure, and let me just say, as the other panelists have said, that it's always a pleasure to be at Partnering for Cures, so thanks for the invitation.
You guys are so gracious.
If there's every year I don't get invited, I'll be heartbroken, so thank you.
Thank you.
So I actually had no inclination that I would ever do research as I got out of my family medicine training. I was about coming out of the 60s, this was mid-70s, I was about to serve the people, helped to start a neighborhood health center in Oakland. And for the next 7 years, I saw people who had diabetes or were about to develop diabetes, and spent my time talking with them. And believe me, I was not trained in my residency to think about prevention in any form. But that was one challenge, how one helps people manage diabetes and the weight management in particular, behavior change, diet. And the other thing that was happening just then was flexible sigmoidoscopy was coming out, and it was being touted as something that family physicians should do for colorectal cancer. Well, I got tricked into going to public health school, and I wound up at Kaiser after that and doing research. And not surprisingly, the two things I got involved in were colorectal cancer screening in a time when there was really no evidence that anything was effective for colorectal cancer screening, and secondly in diabetes. So I happened to, with the help of my boss, Gary Friedman, write a paper, a case control study, a big data study using paper charts actually, over 2,000 patients, we reviewed their charts, and we showed that sigmoidoscopy dramatically saved lives from colorectal cancer, more than any screening test had ever done for any cancer. That paper wound up in the New England Journal, and the U.S. Preventive Services Task Force picked it up, and 20 years before the first randomized trial came out, that little paper changed practice and probably, gave me a lot of advantages in further career moves, which ended up with the great fortune of winding up at PCORI, where I still think that behavior change and judicious screening are important. I'll just make one last point. I hope we talk about this today. I think that screening, as we go from really non-invasive personal habit decisions that have essentially no downsides, but just the challenge there is working with people to support them to make those changes. We go along a spectrum to screening tests and medical treatments for prevention. I'm thinking of bisphosphonates for preventing bone fractures, SERMs for preventing breast cancer in high-risk women, and screening tests, PSA testing, mammography, and other types of screening that do have downsides. And PCORI is very interested in taking a personalized or precision medicine approach to screening and prevention so that we can help individual patients and population managers decide who this makes sense for. And I'll try to get into a few example studies later on.
Fantastic. And I also want to hear from you about how you've already seen things evolve from the time that you were at Kaiser and what was being deployed in a system like that to what is possible today. Lloyd, same thing in terms of some of the healthcare system. So Mike, I want to talk to you a little bit about this. You have been known, I think, in your career for medical philanthropy and certainly the treatment cure aspect, but I would say that you're equally passionate about prevention, wellness, health. Education is another passion of yours too, but were you always healthy? Let me start there.
Well, the question is, if you don't know, you can think you're healthy.
Okay.
So when I think about it, over 20 years focused on medical research, particularly from, say, 72 to 93 till I was diagnosed with cancer. And at that point in time, when they gave me 12 to 18 months to live, I had to reflect what I was going to do. There was little going on in prostate cancer. I knew nothing about prostate cancer. I knew a lot about melanoma, glioblastomas, breast cancer, etc., that we had funded. And I had lost 10 relatives to cancer, and my condition was worse than all of them. So I had to lay down for a few hours and then think, what could I do differently? And so I decided I was not going to eat anything except fresh fruit and vegetables until I figured out what was going on. Now, this was a difficult decision in that I had gone to Berkeley, and in my sophomore year, they opened Top Dog. It is a shrine. And I did not go to sleep literally one night in Berkeley without going to Top Dog before I went to sleep. You know, on a quiet night, I'd have 2 hot dogs before I went to sleep. On a good night, I could have up to 12 before I went to sleep. So I cannot tell you.
I'm not feeling
that,
well right now.
and,
That sounds dangerous.
and if I went to Kentucky Fried Chicken, everyone gave me their skin. So they take their skin off, and I would eat it. So I can't tell you I was a devotee of healthy eating.
I just have to stop him for a minute. I don't know if I've ever heard you talking about this. You're giving more detail than I could have possibly imagined. Thank you. Keep going.
So I decided that there was no hot dog, no matter how good, worth giving up life for. And therefore, until I figured it out, I was going to, pursue this other path that none of my relatives had ever pursued. And I went to see witch doctors in Africa and Indians in the Northwest Amazon and she doctors in China, Ayurveda doctors in India, healers in Russia, with the idea that their medical science didn't look optimistic at the time, so I needed to call on a higher calling. And I read a study where you had 2 brothers in Japan, and one moved here, one stayed in Japan. And within a generation, hormone-driven cancers, in this case prostate cancer, increased tenfold as a probability in the United States versus Japan. So it couldn't be genetics. It had to be lifestyle. And began in '93 this big effort on lifestyle. So most men don't go to the doctor. Women do. And you could find a man that hasn't gone to the doctor in 50 years. And if you don't go to the doctor, you're living. And if you do, you might not get a good outcome. So don't go. And I think this is the dramatic change that occurs. And when I look back, the concept, if you live long enough, you can live forever. So the question is, it's incremental sometimes, but how can you extend your life? And when I think back to just say U.S. presidents, 1 in 3 U.S. presidents has lost a child before the age of 5. The last one being Bush 41. And almost every single one of those children would live today with today's technology. And so, to me, it occurred to me that let's engage early, let's engage before you have a problem, and let's see if you can change the course of history. And it was shocking, Margaret, when I visited the NIH or the NCI. I would say, even in '93, after the cigarette companies, the most disliked group were those that are trying to tell you that if you change what you eat, your lifestyle, it can solve your life-threatening disease. And it took quite a while to convince our medical establishment that there was a link between what went in your body and how you were doing medically.
Thank you, Mike. We'll get into a little bit more your vision for the future in terms of how to better incorporate the science of prevention, preventative medicine, precision health, big data. Can we get to disease before it happens, not just through healthy behaviors, but better technology?
Well, being a science fiction fan, Margaret, there was this movie, Gattaca. I don't know if anyone saw this movie. Maybe we can run a clip from this movie. It's just a couple seconds here. Larry, can we run that?
We're going to the future, guys.
Never understand what possessed my mother to put her faith in God's hands rather than those of her local geneticist. 10 fingers, 10 toes, that's all that used to matter. not now. Now, only seconds old, the exact time and cause of my death was already known.
So we have a lot of technology, and there it tells you when you're going to die. Obviously, I think all of us in this room would want to change that diagnosis, whatever it might be, and what could we do to participate in changing it. But technology will eventually tell us so much. And if you know, what are you going to do? So in prostate cancer, they called it watchful waiting. Today, no one calls it that. They call it active surveillance. What are you going to do in that case?
So for all of the panelists, I want you to think about what's the system that we currently have or lack thereof? What's the state of play today? So from each of your vantage points, where is this topic? And we're going to move towards what do we need to do. But I want each of you to answer that. And I told the panelists that if they don't engage with each other, I will be upset. So I want you to crosstalk as well. So who wants to start? What's the state of play right now? Lloyd?
I'm very encouraged by the state of play. I think that if we look on the healthcare reimbursement side, we've seen an increasing focus on looking at outcomes, not just episodes of care, but really linking reimbursements to outcomes. And as we link the economics of the healthcare delivery system more towards health and maintaining health and achieving good health outcomes, that's going to provide economic incentives even further for the types of innovations that really help us to prevent diseases and to develop early diagnostics. You know, there's been a problem in the past in that a lot of technology related to advanced diagnostics has not necessarily proceeded at as rapid of a pace because there hasn't necessarily been a good business model in the past around advanced diagnostics. I think that could very well change as we have more and more emphasis on outcomes and economic incentives linked to better outcomes.
So I want to challenge you a little bit. I don't know the statistics off the top of my head, but you hear tell that the United States spends a large sum of money on healthcare, and yet our health outcomes across the board are not as successful as other nations. So your optimism is giving me some hope for the future, but I think that we still have some work to do. So any thoughts on that?
Yes, I think one of the issues we have in the United States is our healthcare delivery system is focused on an important but a relatively small part of the health pie. So medical care, genetics, forms roughly a quarter, maybe a little bit more, of the overall picture of health. Behavioral factors, social environmental factors are extraordinarily important determinants of health. And we haven't focused the same degree of attention that we focused on the diagnosis and treatment of acute diseases. We haven't focused on behavioral, environmental, and social factors. I think that's going to be a greater challenge for us in this country, perhaps, than in others. But I do think there's a will to apply the same sort of analytic and academic approaches and research-based approaches that we've seen drive advances in cancer therapeutics, to apply those also to looking at behavioral, social, and environmental.
Now, Margaret,
Yes.
I might challenge your statement.
Kelly had her
there.
hand up. I'm sorry.
Go ahead.
Oh, well, I was just going to say, so I love the whole piece about talking about behavior more. I mean, this Surgeon General is talking about emotional well-being. We're really starting to pay more attention to this. In diabetes, for example, last year, there was $7.5 billion worth of claims in severe hypoglycemia. That should be zero, right? And I think if we start focusing more on the behavioral end, that can really help. So,
Yeah, Mike.
I was just going to say, when you say we invest a lot, the amount of money spent on potato chips in America equals the amount the NCI. So I'm not sure how much we're spending on a relative basis.
Yeah.
And I do think this behavioral issue, when we put out that report on Unhealthy America, which the update will be out again in November, it showed that the number one cost of diabetes was depression. When you looked at absenteeism, presenteeism, and cost. And so I think
That's
this
addressable.
behavioral aspect we've dramatically underscored. And when you think of those studies when you pick kids in second grade to be on your team, the last kid that picked was the heaviest kid. That has been reinforced for a long period of time. So I just want to get that issue.
Yeah, let me qualify. What we're spending is at the tail end of these diseases. I agree with you, Mike. We certainly can and should be investing much more early on how we understand the diseases themselves and ultimately prevent them. But the biggest share of the healthcare dollar is being spent at the most advanced stages of all of these diseases.
Yeah,
Go ahead.
Okay, I mean, from my point of view, the problem is health doesn't happen in the healthcare system. It happens well before it. And it's clear it's much cheaper to feed people healthy food than it is to deal with their diabetes afterwards. But it's not quite that simple. I mean, we do know there's however much money they spend on potato chips, they spend probably 20 or 30% of that on marketing potato chips. And it's clear you don't market healthy food, but there's lots of marketing and other kinds of approaches, as well as sugar taxes, God bless, subsidies for vegetables, and that's well beyond what the healthcare system is funding right now. There are really two problems. One, the return is long-term, and two, it's hard to attribute. But what's changing is with big data now, you can see the impact of those investments more clearly. There's still an issue around getting governments and philanthropists and investors to invest long-term, and some of this is just going to have to be collective spending. But the ultimate business model is clear. Invest in health. If there's an asset, it pays off in improved productivity, reduced depression, better health. It's so clear, and the challenge is, why can't we do it?
So I also want to point out, though, that both you, Esther, and you, Mike, use the term invest versus spend.
Yes.
And, Mike, you've often talked about how if we could take some of the savings, if we can keep people healthier longer, we could invest those savings into sort of the NIH, the research endeavor that all of you are working on, so that if you wake up one morning and you have a disease that was not able to be prevented, then we can have new advancements there. So I also want to make sure that we look at the investment versus spending. And I think we've started to identify some of the societal things that are going on. Why can't we invest more in this? So Joe, I want you to opine on this, because you are investing and spending at the same time at PCORI on issues related to this.
Yes. Well, I'll answer your question. I want to go back to your earlier question, the state of where we are a bit too. But I think we have, through the Affordable Care Act, we have made a major investment in prevention in that those must be covered. Those must be anything that the U.S. Preventive Services Task Force classifies as a B must be covered. That's a radical change. In fact, some people even think maybe it went a little ahead of the evidence, but dramatic change.
So on that one, would you say, as the Affordable Care Act is rewritten, redone, that would be something to advocate to keep? Some part of that?
Some part of that, at least, yes.
Okay.
I think there are some interventions, medical counseling in a doctor's office for weight management, for example, where it's a little unclear whether the evidence is solid enough. But if you think about the 1960s, we smoked at a rate of 50% plus. We now smoke at 15% plus. American diet, for better or for worse, has changed dramatically. We eat a fraction of the amount of fat that we did 30, 40 years ago. We use seat belts, we use car seats, we use bike helmets, now we use skiing helmets. So things change, but I think I just want to point out that, and somebody mentioned behavioral health. We wind up with a society that is spread like the income gap, where a lot of us are living much healthier lives. Mike hasn't eaten a hot dog in a long time. But we also see
I still miss him.
I still miss smoking.
The tofu pups just don't do it for you, huh?
They do.
But we also see that mortality is increasing in lower socioeconomic status whites in America. Dramatic. might be related to the recent election results. But there is something going on, and somebody mentioned mental health. So I think as we get down to those people who still haven't changed their diet, who still smoke or use alcohol excessively, who don't wear seatbelts, helmets, etc., it's going to take it's going to be a different challenge. And I think mental health, depression, hope for the future has a lot to do with how we will extend this very primary kind of prevention to our entire population.
Margaret, I'd like to go back to Esther, if I could, for one moment. She was, the first part of her career, she was an analyst. And I think part of it is statistics. So what do we know? First, we now know that the reduction of sugar, just the sheer reduction of sugar, even in a 6-year-old, thanks to a study at UCSF, will extend your life. And we put out a report, Drink Differently. If you're concerned you're going to live too long, just increase your soft drink intake, and you can correct that problem. So I think this is playing out today in many ways, but I think it's really been, can we get data that shows what happens? And that's what a research analyst does. You're analyzing the data. Now, one of the confusing elements we found early in, for example, prostate cancer is 25%, and I'm rounding these numbers, let's say a quarter of men, what you ate, what you drink had a dramatic effect on the growth rate of your cancer. So you could actually reduce its growth rate for a large percentage of the population by changing your diet. And what would have happened in 3 years took 10, what would have happened in 10 took 30. But at the other end of the extreme, when you see a person that eats well, exercises, etc., there is another percentage, and let's call it 25% at the other, that diet didn't really affect the growth rate of their cancer. And so I think when we talk about precision health, we need the data on ourselves. Some of us, taking certain action will make a dramatic effect. For others, that isn't the key that is firing it.
Esther, I don't know if you subscribe to the idea. You've kind of had this change of heart, maybe. You talked about technology as being frivolous in terms of your investment career. And you have your Way to Wellville project with 5 communities. What is the role of data in that? What are you looking at there?
Yeah. So technology is not inherently frivolous. It was being put to lots of frivolous uses.
I see.
I was more interested in putting it to, things that just fundamentally I thought were more useful.
You mean the Snapchat filter to make you pretty is not useful? Is that?
It might be if it told you that one way you get ugly is
Sun.
getting sun and
Not
too much
using
sugar
sunscreen.
and not enough sleep.
Okay.
But for us, the first thing is these are real places. They're not people who volunteered for a study. And there's a lot of sensitivity around turning people into specimens. So these are real places. We can use big data to measure grocery receipts. We can do school obesity averages. In some cases, we will be doing more precision stuff. But big data to understand what would have been versus what is, you need that to show someone, hey, you should pay for this because look,
I see.
We saved you $5 million from the predicted outcome and stuff like that. But the other thing you can use precision for is behavior change. Some people are motivated. The girls are doing the cycling class tomorrow at 5, join them. Mm-hmm. Other people want to compete. Some people are motivated by numbers. Some people are scared by numbers. And understanding which kind of people do best with what. So we want to give people the tools to manipulate themselves. We don't want to manipulate them more and have it backfire. So things like, this is a free, non-copyrighted idea, a mouse house. Every first grade, have a mouse house, 4 mice, 2 run, 2 sit still, 2 get good food, 2 get bad food. Just watch them for 3 months. You don't need to have textbooks that are controversial with new theories. Just look at what happens to these mice. And if you get sued by people for the ethical treatment of animals, maybe it really But you want kids to see, not simply to be told. Gardens, let them cook. There's a whole lot of social and emotional stuff you can do to get people engaged and manipulate themselves. It won't work for everybody, but it's those kinds of things that we're focused on. So protocols, there are apps, there are the Diabetes Prevention Protocol, Nurse-Family Partnership, but applied with local coaches who are trained and are part of the community, and you help solve the unemployment problem even as you help solve the bad health problem.
I think one of the things Esther talked about, Margaret, was fully costing. Many years ago, we did a study that the cost of a pack of cigarettes with societal costs was $11 to $13 a pack. So if you can buy a pack of cigarettes for less than $11 to $13 a pack, you're actually getting them at a discount to what it costs society. And so I think if we could understand the cost, I'll give you another example, gasoline. All right, the full cost of a gasoline, it might be $8, $10 a gallon, $12 a gallon. We don't take in consideration putting an aircraft carrier in the Persian Gulf, all the military. We've spent 5 to 10 trillion in the Middle East protecting oil lanes. None of that goes into the cost of a gallon of gasoline to try to change behavior. And I think, Esther, what you're driving at here is that the cost of people not eating the right foods, if we subsidize the cost of blueberries, okay, and put a tax on the cost of other things and fully costed them out, we could maybe change behavior by changing the cost to society of these different items.
So Kelly, I want you to weigh in on this from the standpoint of living with type 1, data-driven, right? You need to understand what's happening in your body to be able to sort of live well or feel okay, feel good.
Yeah.
And what the role of data is doing for finding, you straddle a disease that you're both trying to manage, but certainly trying to find out more effective treatments. So you're running the gamut here.
Yeah, and we're just trying to stay out of danger. I was in the emergency room 24 times the first 12 years that I was diagnosed with diabetes.
Because what was happening?
Right, because my blood sugar was getting really low. I was using an insulin that was not nearly as good as the amazing insulins that we have today. And I don't know, we see a lot in headlines about the cost of the high cost of drugs. I don't know, $400 a month for insulin, for the best insulin around to keep me alive. I'm actually okay with that ROI. But it's figuring out how to get that to everyone, right? That's just a little side note. But so another thing, listening to Esther talk about, there's frivolous technology, there's a lot of waste. Then there is also technology like this that shows me what my blood sugar is right now, okay? This is, who here knows someone with diabetes? Right, we all do, and we all see, right, the whole blood thing, this stigma, behavior change. There's a lot of difficult things. It's using technology to make things easier. This is actually only approved in Europe right now. This is at FDA. We can think about things that slow down, but when you use data and you can actually take better care of yourself, that is what is really helping patients. I think the problem is, going back to what Esther said, like these studies that we need. I'm dying for big data to show us more, but like she says, the studies that the payers want, they're long-term and hard to attribute. So I would love to hear more about what studies people think that we could use.
Who would like to jump in on that?
Maybe, Joe?
Well, I really agree that the array of technologies we have for treating and also for screening has gotten pretty massive. And a lot of them are at a state of development where they do not yet serve everyone well. So think PSA testing, think mammography. You can think CT scanning for lung cancer in smokers. All three of them have a chance to detect cancer early. And that some people are benefiting, but in the case of PSA testing, it's been very difficult to show on a population that there's a benefit. On an
I'd like
unselected,
to just challenge that
on
for
an
1 second.
unselected population, you can go. If I were a 50-year-old African-American male with a father who had had prostate cancer, I'd get a PSA test every year. I'm a 70-year-old white male with no family history of any kind of cancer. I've never had a PSA test in my life, and I think that's evidence-based. But same with mammography. Mammography leads to so many cases of a condition called DCIS, ductal carcinoma in situ, that it's, we have, after 30, 40 years, we have not decided what the right frequency of mammography is. So we're funding we're funding a study, a 50,000 person trial in women 40 to 80 of annual mammography, sort of one size fits all mammography, versus targeted mammography based on family history, age at menarche, age at first birth, and genetic markers, personal genetic markers. So to see which one of those approaches, so it takes the population of women and says for some of them, you probably don't need a mammogram more than every 2 years or even less frequently. You need one, or you need something more intense than mammography right now. So same thing, we're doing another one following diagnosis of a tiny nodule when you do CT scanning for mammography, for lung cancer. Another large trial is looking at surgery and radiation versus chemotherapy to prevent breast cancer in women who have a diagnosis of DCIS. So, and in each one, we are looking to find markers of who will benefit from the more aggressive approach, or even who would benefit from more aggressive screening, and who would not. So I think as long as our technologies are so imperfect, precision medicine makes a lot of sense.
Well, I think that what you're bringing up, Joe, is that you talked about them being imperfect. I mean, if any of you men would like to try a mammography, I'd invite you to join us, because it's not so exciting, and maybe not something you look forward to.
Well,
I'm sure you have other things.
I'd like to compare that with the digital rectal exam.
Okay. Who would have thunk it, right, this morning, comparing our medical things. I actually think that what we're saying, though, is that we are not satisfied with these tools.
That's right.
We are absolutely not satisfied with how they're being deployed, are they patient-centric, and then Joe, you're talking about needing these big data sets to analyze where can we deploy them. How are we going to move this system forward? Because I think there is sort of a will and a hunger and a yearning for this, but is precision medicine going to catapult us over some of that? Lloyd, you looked like you wanted to jump in.
Well, to return to a point that Kelly made, it's only been within the past 2 decades that we've really had evidence that tighter glucose control leads to better outcomes. I mean, that was not all, we had no way of measuring really blood glucose in anything resembling real time up until that time period. And so the conventional wisdom was, well, you give a fixed dose of insulin, and then you look for glucose in the urine, and you don't want people to bottom out and become hypoglycemic. But the technology has driven the studies that then demonstrate the improved outcomes with tighter glucose control, and then that is the data that people depend upon to look at whether or not their behavior should change. I mean, should you monitor your glucose on a more continuous basis? And so I think there is a virtuous relationship between technology driving better outcomes and then driving changes in behavior.
And outcomes beyond A1C, for example, in diabetes, and understanding quality of life, understanding distress, not just depression, but that whole range, and how that actually impacts adherence and how well we do.
So I'd just like to address 2 issues, if I could. One, I think an area here that we had covered is this testing issue. The data is going to improve. All the tests we have today, we can assume are a midpoint. Okay, they're a path until we can just sequence your blood and everything's in your blood, and we know we can forget all these other tests, and they'll give us early detection. But if I just want to go back to the PSA test for a moment. Obviously, I would not be here today if it wasn't for the PSA test. 5-year survival rate in the United States from diagnosis, 99% plus for prostate cancer. 5-year survival rate in parts of Scandinavia, advanced societies, 50%. Very simple. It's diagnosed substantially later in Scandinavia, who doesn't do many of the countries, PSA test or other tests. So I don't need too many more statistics here to figure out. And what has happened in America, the challenge to the PSA test in the last 24 months, if you survey urologists in America, they will tell you now that they're diagnosing prostate cancer later because someone read some announcements. Now, generally, the public doesn't pay any attention. When the government tells you not to get your test for breast cancer, no one stops. When they tell you not to get PSA, a large percentage of the population. When they tell you that vitamins don't do anything, people buy more vitamins. So we don't necessarily have a complying population here, but our imperfect early detection test for colonoscopies is a pretty, it's 90-90. Okay, it's a pretty expensive decision, and the same thing for PSA. I'd like to just touch base on one thing. There are 3 diseases that I think about, and I'm sure there's many others, where the person is perfectly fine, your child, when they leave the house, but the parent never relaxes, never. Yeah. One is type 1 diabetes. You don't know what happened during the day. 2 would be epilepsy. There's no problems all of a sudden. And 3, food allergies, which your work at Stanford under Carrie has been the leader in the country and maybe the world. So I just want to stress that I've actually been surprised we haven't done even more.
Right.
Okay,
Yeah,
because we have not measured, I just want to mention this, the loss of productivity to the mother, the father, the brother, the sister, the grandfather, whoever it might be, and the fear of what's occurring that you said goodbye to your child and you don't know if your child's coming back, even though they're perfectly fine when they walked out of the house. So I feel, I've been surprised we haven't pushed these 3 more.
Well, that topic has come up here, Mike, across, I heard it yesterday in a couple of different panels. Why do we have certain diseases that are just sort of lying there in wait? Is it the science? Is it the incentive system? You know, what thoughts do you all have on that?
Well, I think it is waiting in many cases for evidence of something that really looks viable. If you've got a condition that you just really don't have either a preventive measure or a test for, you're back in earlier basic science. Can I just say one thing about your notion about data? Mm-hmm. It's true, it's a sad fact that a precision medicine approach is going to take more people to, instead of relying on an average effect and giving the same treatment to everyone, to try to understand what works for whom is going to take very big data. And to just point to 3 really hopeful signs, I think the Precision Medicine Initiative from the NIH recognizes that it takes a lot of people and a lot of data to understand the subgroups in our population, who's at risk. I think genetic testing is going to help us in the future know exactly who ought to be screened more frequently and who should be screened less frequently. We're beginning to get there even in breast cancer. But 2 other efforts are PCORnet, funded by PCORI, which has 100+ million persons, electronic health record data, patient involvement and governance, doing both randomized trials and big data studies, and the Sentinel Initiative from the FDA. Those are 3 very large studies. We're talking in the last 2 about 100 million persons plus. And in the Precision Medicine Initiative, they recognize that they're going to have to get, they're large with 1 million persons, but they recognize they'll need to continue growing. So that's really it. Fortunately, it's at hand. EMR data and the capacity to store and analyze big data is at hand, so we're blessed.
Yeah,
Esther.
This is not my area, but I assume that most of those parents would want some kind of wearable on their kid that would do, depending on whether it's epilepsy or allergy, you know, you can monitor skin temperature, pulse rate, all kinds of things, and presumably, you know, 1 is the parent gets called, but 2, it creates some kind of alert for people around the kid, and it's not a long-term solution or cure, but it's certainly something I would want my kid to be wearing 24 hours a day.
Absolutely. So how do you put together these 2 themes, though, Esther? This is a separate question. We're talking about needing more people to be able to do precision medicine. You talked about PMI, Joe, you know, the numbers of people that are going to be enrolled in that cohort study, and also some of the things to be able to understand, you know, should we do A or B? And you're dealing with 5 communities and trying to understand individuals' sort of perspectives on wellness, health, accessing the medical system. So, we need it all, I would presume, but how do you start to blend those systems together?
Well, there's this wonderful term, post-market surveillance. It's like, in the past, you do clinical trials only before, and then out they go and nobody knows what really happens. Now, again, we don't want to turn people into specimens, but I would love for people to become their own specimens. And, everybody knows their blood type. Why don't you know your glucose level? I think I would love 7-year-olds to study this. Eat the muffin and the sugary yogurt, and then watch your behavior in class, and then the next day have the oatmeal with the scrambled eggs, and see how you behave differently, see whether you run better, monitor your sleep, just as part of a normal education. And that will change people's attitudes, and it will create huge amounts of data in a world where people, it's your own data, it's private if you want, but people will realize, gee, this stuff, nobody's going to make a little avatar and poke pins in me. The data's useful. Sorry, Kelly.
Oh, yeah, what Esther's saying is just brilliant, right? So it's sort of like there's no room for noise anymore. The randomized controlled trials, it's necessary, but it's not sufficient. We need to look at so much more, and big data should be able to allow us to do that. Something that the diaTribe Foundation is trying to do with Esther's help. She was at a gathering that we had earlier this year called D16. We were talking about sort of a show-up day. If you could get, right, everyone in Congress to just measure their blood sugar one single time, their staff, everyone. We don't know one single person in Congress or the Senate who has type 2 diabetes, okay? And people say, oh, there's gotta be one. There's gotta be one. No, there's gotta be like 50, But it goes back to stigma as well. And so if you could think about this big data set, even if it were anonymous, what it would look like. I think that moving beyond the traditional trials is just critical.
So Lloyd, how are you managing this in terms of training new fleets of physicians to go out there and work in this environment? And what are they bringing to the table? What are they, wanting?
Sure, I think throughout the training of health professionals today, we're training the learners for tomorrow. So we know that the knowledge base is going to continue to grow and change. And now more than ever, we need a multidisciplinary, multi-talented workforce in healthcare delivery. So for our medical school, we have students that are focusing in areas of data science. Given that we're well integrated with the rest of Stanford, we have students that are taking computer science courses. We have some that are looking at the sociological and socioeconomic determinants of health. But it's going to take a much more diverse physician workforce in all aspects, and a much more diverse and inclusive healthcare workforce across the board to meet the healthcare needs of the future. I want to return also to a point that Joe raised about the tremendous power in EMR, data, electronic medical record data. And one of the impediments we have right now is the lack of interchangeability between and among the data that's in various different health systems or even our individual physician's office. I can use my ATM card to withdraw cash, perform financial transactions at virtually any ATM in the country, around the world. And the reason for that is that the financial services companies realized a long time ago that there had to be that interchangeability, that I wouldn't bank with a bank that only allowed me to use my card with their ATM machines. Today, if I want to get my medical records from a physician on one side of town to the other, by and large, it's probably going to be with paper copies or a CD that has lab results or images on them, or it's going to be through a fax records, but we don't have the type of interchangeability, interconnectedness that we need, first of all, to enable really good, high-quality patient care, and certainly that we need to enable the type of data science that is driven by large amounts of data. And I have a suggestion as to how we can really move things forward, and that is to develop technologies that empower consumers, empower each of us to own our medical record data, to be able to get it in the form that we want to receive it, to manage it, maintain it, allow others to access it as we determine to be appropriate, but empowering consumers to have access to healthcare information is going to be a critical part at providing the incentives that help delivery systems to be much better connected than we are today.
Do you have a forecast of how long you think that will take for that to happen?
You know, I don't, if I have a forecast, it's merely a gut instinct. It's not based upon any particular knowledge or information. I don't think it's going to take that long. I think the building blocks are there, and I think the demand, we're starting to see elements of the demand, and that's what, of course, is going to encourage the innovation and the entrepreneurial focus.
I was going to
Margaret,
say
I'd
that
like
the data that we had from polling didn't seem to matter in this election, so gut instinct, is a good thing. Go ahead, Mike.
Margaret, I'd like to just comment a couple things. You mentioned the word stigma. So I want to just comment briefly on stigma. It was the mid-1980s, and we published these comic books called The Superheroes Meet the Myth Monsters to give to K-12 schools, with the idea that all the superheroes had a problem. Some had type 1 diabetes, some had epilepsy, etc. And so the kids, when they were reading all these stories, discovered these superheroes, and gosh, that wasn't so bad. So when they see a kid taking an insulin shot, they don't think they can think about that superhero in that comic book. So I feel stigma's changed. To tell someone you had cancer 30 years ago is a lot different today, with 16 million or more people living normal lives. Two, I think responsibility, who has responsibility? As you know, Margaret, one of the things we worked hard on that Affordable Care Act was getting personal responsibility, and we were unsuccessful. So, don't ask what the country can do for you. What can you do for the country? Well, if everyone could return to the average weight of 91, we would have contributed $1 trillion to the country. So there is something we can do. But there's one group that cannot shirk personal responsibility, and that's for-profit companies. Yeah. They have to pay the medical cost. And so a company like Safeway under Steve Bird provided free mammograms, free PSA testing, free colonoscopies to their employees to encourage them, rewarded in different ways those that reduced their body index and so on and so on. And they had now a healthier population, and 80% plus of that population were union members. So to me, it comes down to who's taking responsibility. In Mexico, the government took responsibility. They put a 10% tax on soft drink and a tax on junk food. And surprisingly, sales of soft drinks dropped 12% the next year. So what did the soft drink companies do? They've substantially increased their advertising to try to get it back up. But it won't be long before you're going to ban advertising, like we banned advertising of cigarettes here. So I just say who has responsibility, and it's spread between the individual, let's say the company or the organization, and the government, and all three can accelerate our activities. The last thing I just want to put on the table for the panel is, how many times do you go to a dentist? Do you only go to a dentist when you have a cavity, or you need a root canal, or you have a problem? Or do you go to get your teeth cleaned? And so I think for a large percentage of the population, they go when they don't have a problem. And I think that is the challenge in this precision health issue. Can we get to people to go and engage the health system when you don't have a problem? What's the best time for a company to finance? When you don't need money. What's the best time to go to a doctor? When you don't have a problem. And so I think if we could collect this data, et cetera, and get people used to this issue, we could change a lot of what happens in medicine.
Lloyd.
I would just add one thing to what Mike said. I think getting people to engage in going to their doctor and getting them to engage in their health and in the behaviors that we already know confer less than favorable outcomes related to health.
So Lloyd, I have a question on that. How do you also make sure that your medical students really want to help these populations, these large-scale social problems, things like diabetes, obesity? I feel like all of the extraordinarily bright young associates who work with me at Close Concerns, they go on and they're pulled in by cancer. They're pulled in by orthopedic surgery. They're pulled in by areas that really aren't about these big problems. How do you change that and want to make them heroic?
Well, as I look at people coming into health professions today, there are more people desiring of medical education today than proportionally than ever in our history. And
Absolutely.
As I look at our incoming medical students, our residents, our fellows, our young faculty, these are people that are really motivated by making a difference in the lives of others. And getting back to technology, technology is an enabler. It's not an end unto itself. And Mike, at dinner last night, you mentioned Nisbet's work on high-tech, high-touch. And ideally, what technology should do is enable high-touch. It should provide the information, the data, and the analytics that enable a healthcare provider and a patient to interact in a compassionate and informed way. But it shouldn't be pulling healthcare providers away from patients. It should be enabling the relationship between healthcare providers and patients to be more meaningful than it has been in the past.
So it should
But
be.
I would argue, though, it's really important to go beyond the healthcare system. We need gym teachers, we need doulas for women who are pregnant, we need cooks and
Right.
farmers and people like that to engage and, again, create a culture of health. Thank you, Robert Wood Johnson, but also a culture of accountability.
Yeah.
There's lots of well-meaning programs that never measure their impact, and we need trained people who are accountable to help cultivate health in their communities, not by going around arresting people, but by motivating them, incentivizing them, changing the culture.
Kelly, you were.
Oh, yeah, I just wanted to respond to this one piece about the medical school thing. I mean, it is amazing. And medical school demand for that, nursing school, et cetera. I mean, there were 9,300 people who applied to UCSF last year for medical school for a class of 165. The new Dell school, 5,500 applications for 45 spots. And we see the same thing in nursing, in community health, et cetera. But we also have to make sure that they are graduating into systems that value them. We talked to a primary care doctor the other day who said, I used to be a doctor, now I'm a typist, right? So we have to make really sure that we're taking care of them as well.
So I was going to mention, when you were talking about the ATM machine, my ATM is my Kaiser card. So when I go, it's all there. But your point, Kelly, about physicians, kind of hiding behind computers, Joe, when you were at Kaiser, how were they thinking about that? Because Esther, you're bringing up points about individuality and, people being people and all having different motivations. So is there anything that you can offer there?
Well, I'll just say that while everybody recognizes that the electronic health record is essential and has huge advantages, I don't know what Lloyd would say, I don't think physicians or electronic health record vendors have yet figured out how to get away from this fact that physicians are turning into clerks. And we've got scribes in many places now, and the hope that we will see a new generation of electronic health records. A new generation of physicians helps some. My son is a young doctor. He really doesn't complain about the electronic health record. But it has been a challenge, and I think the electronic health records have a long way to go before either they serve physicians and patients as well as they could, or before they serve this capacity to do research.
But I want to point out real quickly, so Janet, in her Time Equals Lives talk, was talking about end of life and listening and being present and being focused and kind of, getting off the treadmill. I have a friend who recently died of breast cancer, and she, they were so hungry for each next clinical trial, right? I mean, that was between her and dying. And they went up to Dana-Farber. She had this, magical physician who is the sort of guru of triple-negative breast cancer. And I kind of knew, I was like, this guy sounds pretty amazing. So they go up and they sit in his office, And he looked at her, and she was, kind of agitated, I think, based on the story, what's my next trial? And he said, let's focus on you. Let's not focus on cancer. Let's focus on you. And then they were able to make a plan that allowed for what her outcomes were that she wanted in terms of being able to feel well and all of that. And I think that's a story to depict the end of life and when we don't have any more options. But I think it's equally relevant to what we're talking about in this panel, which is how do we create systems that are big and they're based on data and numbers and crunching, and keep it to the individual and their motivations. So that's going to be my final task for all of you. What do you have to offer, to that question? Who wants to start?
I'll do one thing that I was going to mention in this context anyway. So in Spartanburg, which is one of our communities, the local medical college has a program called the Other 45. You spend 15 minutes with the doctor, which may be 8 to 10 minutes of real interaction. And we can talk about EHRs separately. They definitely need to improve. But after that 15-minute interview, you go with the resident, and the resident says, so did you understand what the doctor said? Does the advice make sense? Can you actually get to a grocery store? Can you afford the medicines? Can you make it to the next appointment, or do you need help with being picked up? Understanding the patient's life and the context in which the doctor's advice may or may not make sense, the patient may not have heard it. And I mean, just for what it's worth, I recently had cancer, and I asked them, would you mind giving me the instructions on a piece of paper when I leave? Because last time I didn't remember them. And they said yes, but then they didn't do that. I mean, medical practice really needs to change, and the medical system needs to understand that, if I feel bad, I'm not deciding between one drug and another or one doctor and another. I'm probably deciding between, should I go out and have a stiff drink? Should I buy a new skirt? Or should I really just go get the car fixed because that's, but people's lives are not centered around the healthcare system.
Right.
Go ahead, Lloyd.
Lloyd?
Sure, I think one area very exciting for me and for us is looking at consumer-focused technologies. I think empowering everyone to be more engaged with her or his health will be a great thing for healthcare outcomes, and it will be a great asset for healthcare providers. We, in our healthcare delivery system, we allow people to elect. We have a program called ClickWell that if people want to interact with us electronically, either through a phone call or a telemedicine visit or secure email, they can choose to do that. And we also gave people the option of, do you want to receive all of your health care, assuming that you don't have certain conditions that we feel would be inadvisable? Do you want to receive all your health care in this electronic way? And virtually no one said yes to that question. So the system allows people, if you're not feeling well at work at 3 o'clock in the afternoon and you want to talk to a doctor at 8 p.m. when you finish your work, you can sign up for a video appointment or a telephone appointment. But still, people still want to have a primary health care provider. And for that primary health care provider, the more each and every patient knows about his or her health, the more engaged she or he is with their health, the more effective the provider is going to be able to work with the patient using the enablers of technology to achieve better healthcare outcomes. It's empowering the partnership between physicians, other healthcare providers, and patients, and enabling healthcare providers to interact with communities in more effective ways, just as Esther described. That's what really is going to change the face and the character of healthcare.
Kelly, what's your one thing?
Yeah, I love that. I mean, we're definitely going toward, bringing more humanity in, which is great. I love Esther's, culture of accountability, and I think that goes in so well with what Robert Wood Johnson is doing on culture of health. I would like to see patients focus more on something that's kind of boring, waste. There are absolutely ways to reduce waste, and I also think that there are ways that we can work with manufacturers to figure out how they can reduce waste.
Well, first of all, this panel has been fantastic, and I think I've heard every one of them at some point say that we need a rather dramatic change in not patients, but people's preparedness to engage in prevention and in the healthcare system. We've also heard, and I love Esther's ideas as well. There's a lot to talk to the public about what we know and what we don't know, about how research works, that would prepare the public to actually participate more fully in research, including clinical trials, which would speed them up. But equally important is preparing physicians, and I'm really heartened at the appearance of some new medical schools like Dell, and also now Kaiser Permanente has taken one on, and I just learned yesterday that Geisinger has acquired a medical school. So some of the progressive and advanced principles of population management and prevention might actually filter down to medical students like they didn't in my day. And then systems need to be prepared for this as well. I'm thinking of the Open Notes Project, and I wish I could remember who the great physician is in Boston who did that, but the notion that the electronic record is open, really, truly, the progress notes, what the doctor said about me is right there. That's the future.
So the concept you're talking about, we covered in our Prescription for Innovation report. It's called #HealthCitizenship, and it's this concept that we heard loud and clear in our interviews with stakeholders about what the next administration should think about as being a theme of, everybody needs to be thinking about their own health citizenship, whether they're patients yet or not. Mike, I'm going to leave you for this last point because as Mike and I were talking about last night, I emailed him on the morning after the election and said, Mike, I've always relied on you for wisdom and guidance about our future. Tell us, what you think about the future vis-a-vis, we've just had an election. We know there's going to be changes in the healthcare system. You've spent your life kind of devoted to this, so give us some words of wisdom for what to expect and what we should be doing with it.
I think we're just in a transition period, and a lot of our discussion relates really to the transition. My grandchildren are growing up totally differently, and you just have to give a smartphone to a 3-year-old, and they're all over it. When I get my devices back, I got to get the picture they put off on my page off. I have to try to figure out how to get back to what I know how to do. So I think it's a transition. It's quite possible in the future they're all going to be elected, for the digital interaction in between playing a esports video game. So I think it's a transition period that we're in. Looking at the facts has only begun. If China has 10% of the hormone-driven cancers that the United States does, they're still human beings. Why is that? And why was it so hard to convince people that lifestyle made a difference? Now that we've delivered every fast food company to them, their incidence of hormone-driven cancers in certain cities have tripled. So we have enough facts here to make a decision. So I see this transition, and I think the most important thing is the idea that health is a continuum. If the public had more confidence that there were solutions for problems, and it was easier earlier, they would engage earlier. And so it's the question of, do I have enough knowledge or confidence that there's a solution to my problem? And I think the promise here that there is, yes, we might have modern techniques in urology, but there's 14,000 urologists, and what do they know about immunology, et cetera, when they go see their doctor? So I see this kind of a transition. If I made it to analogy of another industry, many of the environmentalists are willing to deal with the concept of natural gas as a fuel in cars until they're all electric or something else. And so they don't want natural gas, but it's better than our existing system, and we have an abundance in the United States. And so I think we're in a transition period. One of the questions that we always ask myself is, in polio, the largest number diagnosed in any one year was 60,000. The most that died was under 2,000. Yet it was declared a national epidemic. Now, we were dealing with a very caring generation, those that lived through the Depression and World War II. They were very concerned about their children, this very demanding baby boomer generation. But we mobilized the country on polio with relatively small incidence relative to what occurs in diabetes or other diseases today. What can we learn from what occurred there that we could repeat that process? And so, to me, we are transitioning to where everyone will accept digital interaction, etc. And how do we educate the public that they can have confidence? I go to the doctor every month and have for 23 and a half years. I'm never apprehensive on any diagnosis, any blood tests, because I go every month. I would probably be apprehensive if I went once a year. Now, I can afford to go every month. Many people can. So is there a way we can make it easier and cheaper to engage in the healthcare system? And we all know it'll be a lot easier to treat people if we can diagnose early, just like going to the dentist. If we can clean your teeth, your outcome will be better. So I think, Margaret, we're in this transition that we need to deal with, but we need to have confidence by the public that our system will serve them well if they engage.
Thank you. And I think we also, based on this panel discussion, would subscribe to an epidemic of wellness and of sort of being involved in our own healthcare. So I want to thank our panelists for this great conversation, and thank all of you.
And thank you, Margaret.
Thanks, everybody. On to your panels and partnering and all sorts of other things. Thank you.